So I would like to welcome everyone. Nami Yavapai and Northern Arizona Peer and Family Coalition are putting on Mental Health Monday. So welcome everyone. This is exciting.
Absolutely. Okay. Thank you, Kathy. My name is Lori, and I would like to introduce our presenters. We have Alfonso and Talina today, and they are in Nogales. Talina Pimienta is a peer recovery support specialist and a peer navigator at Hope Inc. She attended the Northern Arizona University and graduated with a degree in early childhood and special education. She's worked in the behavioral health field for over 12 years as a parent aide, a recovery coach, a medical assistant, and a peer support specialist. Kalina was diagnosed with bipolar 1 disorder in 2020, which helped her prioritize self-care and benefit from local behavioral health resources. Talina was certified as a peer support specialist in 2022 through Hope Incorporated. Welcome, Talina. And we have with Talina Alfonso Villarreal. He's a peer recovery support specialist and a peer navigator at Hope Inc. in Nogales also. He's a native Arizonan, went to Arizona State University. He was nominated for the Uplifting Resiliency Peer Support Award in 2023 at the Arizona Peer and Family Career Academy Conference. He's worked in the behavioral health field for 7 years as a peer support and at 2 different peer and family run organizations. Alfonso was diagnosed with bipolar 2 disorder in 2019 and is passionate about teaching others tools to help them live fulfilling life with mental illness. He was certified as a peer support specialist in 2017 through Wellness Connections. So thank you both. And I just want to add that I've had the pleasure of working with both of you. And I know that you put this presentation together and it's very powerful. So I'm going to turn it over to you to share your screen and take it away.
Can everyone see the screen?
Yes, we can.
Okay, perfect. Sure, that's not interfering with anything. Okay,
If you could get a little closer to your microphone, maybe.
the microphone is on the ceiling, so we'll just talk louder.
Okay, thank you.
Okay, good morning, everyone. We're very grateful that everyone can be a part of this because I just think it's so important for everyone to be educated about mental health diagnoses. We think that, now that mental health is a bit more popular, in culture, people talk about it a bit more. Anxiety and depression are more well known. And when it comes to things like bipolar disorder, a lot of people can use it without knowing specifics. So we're just gonna dive a bit into everything. We both have lived experience. We encourage everyone to ask questions. So we're gonna start off with talking a bit about hope.
Yeah.
See my new number. I would like you to give it to you in case something happens to us.
Oh, you have a new number?
Hey, this is Brenda.
Okay.
Okay. So we work for a peer-run organization that is Hope, and something that we like about this organization is that we are able to share our lived experience with members. We have both had the pleasure of working with people who have bipolar disorder, and I think it does allow you to see things in a different perspective. How do you feel about that?
Yes, you have the opportunity to share experience and see how they've been dealing with their symptoms in a different way and how you prioritize your care and how you find resources about it.
So we're gonna go ahead and start with a presentation. So A lot of the images used throughout this PowerPoint, we chose ourselves because they do show the juxtaposition of like how the high highs and the low lows can occur in bipolar disorder. So I think they do offer really good visual aid. We also include a lot of graphs, which I think are very helpful to people who do not know anything about bipolar disorder. So I think it can be very helpful if you're ever explaining it to someone to learn a bit more about those graphs. So we're gonna start off with the symptomology and the types of bipolar disorder.
So bipolar disorder is a disorder associated with episodes of mood swings ranging from depressive lows to manic highs. The exact cause of bipolar disorder isn't known, but a combination of genetics, environment, altered brain structure, and chemistry might play a role. Manic episodes might include symptoms such as high energy, reduced need for sleep, and a loss of touch with reality. Depressive episodes might include symptoms such as low energy, low motivation, and loss of interest in daily activities. Mood episodes last days to months at a time and might also be associated with suicidal thoughts. Treatment is usually lifelong and often involves a combination of medication and psychotherapy.
So when it comes to bipolar disorder, what really defines it is the high highs and the low lows and the length of time. I think a lot of people can get a bit confused because they think, oh, you know what, it can happen from one day to another. But in actuality, there are, certain timeframes that really define the diagnosis. We're going to go into a bit more detail. But I think some of the myths that we've heard of are things like, um, you know, this person in my life was acting one way one day and this other way the other, right? Oh, they're so bipolar, or the weather's so bipolar, right? But those myths, I think, can create this image in people's mind that isn't accurate, and we just think it's important to clarify that, just so everyone can, not only be aware of this disorder, but also be aware of how normal emotions just like come and go, right? Emotions are fleeting for everyone. So starting off with this introduction. This used to be called manic depression. Now that word is not used anymore. Focuses a bit more on, both poles, and that's where bipolar disorder comes in. Okay, so right here, we're gonna talk a bit about the diagnostic criteria for bipolar 1 disorder that needs to include a manic episode and mania informs bipolar 1. So mania can consist of symptoms, 3 or more, for a week or longer. They can be things such as inflated self-esteem or grandiosity, decreased need for sleep. They're much more talkative than usual, and there's pressured speech. You just can't get a word in. The flight of ideas, thoughts, gold. Distractibility, directed activity, and excessive involvement in risky activities that are also pleasurable. So that is mania. A lot of times mania can include hospitalization and psychosis. Not always, but that's definitely present. And when it comes to the depressive episode that may be present in mania, it may not.
Recording in progress.
A lot of times people think that in order to have bipolar disorder, you have to have both. But for bipolar 1, mania is the most important. Depression is oftentimes present, but it doesn't have to be. So we're going to go into bipolar 2 now, because what really rules bipolar 2 is the depressive episodes. We're going to go ahead and start with talking about mania first. So just like mania, hypomania has these symptoms. So it's these 3 or more symptoms for 4 to 6 days. So when it's in that range, that's when it can be hypomania, but also it's a lot less intense. It really interferes less with functioning, and with any diagnosis, it really matters how much it interferes with that person's functioning, both interpersonal relationships, maybe career goals, school, things like that. And when it comes to hypomania, Oftentimes, this doesn't include psychosis or hospitalization, but I know nowadays they're starting to say it can include psychosis, but that would, need to be talked about with a doctor, with a psychiatrist, because we know psychosis can be involved in depression as well. So with the depressive episode symptoms, these are more well known. So 5 or more of these need to be present for 2 weeks or longer, and that talks about feeling low, irritable, or appealing tearful, reduced interest or pleasure in most activities, marked increase or decrease in appetite, significant weight loss, difficulty sleeping and waking, increased agitation or lethargy, fatigue, feeling worthless or guilty, and you're less able to make decisions or to concentrate. And there can be passive or active thoughts of suicide and just constant thoughts of death as well. And I think it's really important to start off with these diagnostic criteria because they give you an insight into what really defines bipolar disorder according to the DSM. And that is the Diagnostic Statistical Manual of Mental Disorders. Anything you wanted to add to this slide?
No.
No? Okay, we're gonna go ahead and continue.
There are 3 main types of bipolar disorder. Bipolar 1 disorder is the type that involves manic episodes that last at least 7 days. Bipolar 2 disorder is the type that involves less severe episode of mania known as hypomania. And cyclothymic disorder is the type that involves chronic mood instability without extreme mood episodes.
When it comes to bipolar 2, I like right here that they put that they're severe episodes of mania, but a lot of times people can think bipolar 2 overall is less severe, when in reality, because the depression is present for longer, it can always be a case-by-case basis, right? Just because someone has bipolar 1 doesn't mean they have like a more severe diagnosis overall, because you never know what role the depression and suicidal thoughts play. And when it comes to cyclothymia, it falls into bipolar disorder as well. It's kind of like the cousin. You'll kind of see it in the graphs, how it kind of like relates to those, but there is that mood instability. It's just a bit less specified. Okay, so these are the graphs that I was talking about, and I think it's really important to show things like this because visual aids are not only helpful when learning, but I think they can be helpful to anyone who is interested in mental health. Starting with the graph on the left, all the way at the top we have mania, then a little bit lower we have hypomania. We spoke about both of those. In the middle we have euthymia, or what I like to call a baseline. I don't really like using the word normal because that definition is constantly shifting and I think it has like a negative connotation. A little bit lower we have minor depression, which is also called dysthymia, and then there's major depression all the way at the bottom. So if we follow the red line for bipolar 1 disorder, you see how it hits mania, right? And that's what really defines bipolar 1. In this case, it also hits major depressive, so it's that high and that low. If we go ahead and follow the yellow line, we see that this one hits hypomania and hits all the way at the bottom to bipolar 2 and depression. So this is bipolar 2, sorry about that. So it hits all the way down to major depression, and that's bipolar 2. And right here, the blue line, this is an example of cyclothymia. So it hits hypomania and it hits minor depression or dysthymia, but it never hits mania and it never hits major depression, right? And the length of these episodes isn't as specific, but it exists in that middle ground. And this graph on the right, this one's, a little more scrambled, but if we follow the line for unipolar depression, here you can see how it never hits hypomania or mania, but it does hit that major depression. Over here we have bipolar 1 in the light blue. If we follow that, 2 weeks or longer, all the way at the bottom with major depressive, it hits mania for 1 week or longer, with bipolar 2 with the green, Right here, it hits depression, hits hypomania with cyclothymia again. It never hits mania or depression, but it exists somewhere in between. And when comparing these to each other, I think they really clear things up for anyone who's learning about this. Anything you wanted to add?
No.
Perfect. Okay, let's continue. Now we're gonna go into a bit more detail with mania.
So common symptoms of mania are decrease of need of sleep, higher sex drive, noticeable talking more, feeling euphoric, engaging in risky behaviors like self-harm or spending excessive amounts of money, and increased energy levels.
Since we are peers, do you feel like there's any symptoms in mania or maybe hypomania that you've experienced that we haven't talked about so far?
No, I feel like in general, just the need of more stimulation when you're in mania. Like maybe going to talk with someone more than usual, like doing things that you really like or enjoy more than usual. Yes.
For me, I think some things that I haven't seen mentioned often, but I have seen other peers talk about online, are how certain symptoms and senses can be increased
Yes.
during that time.
Uh-huh.
An example of mine, music sounds so good when I'm in a hypomanic episode. Like it sounds amazing. I love it. Like certain songs, especially if I'm listening to them for the first time, they sound amazing. So senses can be very heightened.
Like you're like hypersensible.
Right.
Sensitive, yeah.
Right.
Mm-hmm.
And irritability
Yes.
also plays
Yeah.
a big role in here. Irritability can be present in mania or depression, but a lot of times it can play a role into these episodes as well. So now we're going to talk about symptoms of depression. So some of these can be low mood, changes in appetite, sleep disturbances, agitation, fatigue, and difficulty concentrating. We mentioned these. This can be present in both bipolar disorder and bipolar 2 disorder. And when it comes to cyclothymia, this can be present to a lesser degree. But I think with depression, that sadness, that lack of hope can feel like a crash. My experience in bipolar 2 with this, hypomania can kind of seem like a vacation. And then when the depression hits, I don't know, like there's that disappointment, especially with all those goals you set. And since hypomania for me doesn't necessarily get to the point of like a crisis, or at least it's never gotten there. When the depression hits, it's almost like twice as disappointing because I usually spend more time in this area. What would you say about depression in your experience, Lavina?
Since I have bipolar type 1, I usually are in mania or hypomania or mania. So for me, I struggle more in trying to calm me down or getting to those lows.
Right.
So I don't usually feel depressed, but I feel like where I struggle the most is with concentration and get things organized and done. Yeah.
Definitely. With that concentration, I know that interfered a lot with my schoolwork, especially. No matter how much time I spent on it, like it could not get done. And it doesn't add to anything that I was already experiencing other symptoms. But I think this can be a really tricky place for anyone who has bipolar disorder.
Mixed episodes. Mixed features refers to the presence of a high and low symptoms occurring at the same time, or as a part of a single episode and people experiencing an episode of mania or depression. In most forms of bipolar disorder, moods alternate between elevated and depressed over time. A person with mixed features experience symptoms of both mania and depression simultaneously or in a rapid sequence. Those are the worst.
I definitely agree. Oh my gosh, what can I say? Mixed episodes. I don't wish this upon anyone. For me, it is the worst. What they can say about this is that this is when someone can feel like really depressed and have the energy to do something about it, right? So that's where they can see a lot of suicide attempts, unfortunately, like completion. But these mixed states, for me personally, like I don't want to be in my body. The irritability is like at an all-time high. I usually just sleep a lot more because I don't want to exist when I'm feeling like this. They don't last too long, but I definitely remember them, even if they just last like 1 or 2 days. It's just, oh, it like, it feels like I'm being torn into like two different parts, but it stays inside. So it's just like really uncomfortable. I feel like I can't escape myself, but it's the first thing I want to do. How would you describe mixed episodes for you?
Yes, it feels like there is that like you are about to explode and there's no escape or like no fuel or something that really that feel of that you want to explode. Like for me, one of the mixed episodes that I usually get is like racing thoughts, but like difficulty to concentrate and do something about it. So I have like all those thoughts and I know what I need to do and I have the impulsivity and the energy, but I can get organized or concentrate to actually break it down and do something about it. So I'm just like feel like I can be in myself.
Yeah, I mean, long story short, this is when we're at our worst, probably.
Or when you're like super, super tired
Yeah,
and your body is tired and you can actually feel like you want to go to sleep, but it's impossible, but you have a lot of energy and spend like 2 days in a row without sleeping
right.
and functioning like usual.
Yeah. I've heard a lot of clinicians online refer to mixed episodes as wired but tired. So that's something you can use to remember what these can feel like. So now we're going to talk about the age of onset. The average age of onset is about 25, but it can occur in the teen years or more uncommonly in childhood. It affects men and women equally, with about 2.8% of the US population diagnosed with bipolar disorder and nearly 83% of cases classified as severe. And that is information from NAMI. Here's a graph just so you can see a bit about this. Whenever I see these statistics, I hate seeing them because I remember these symptoms really interfered with my life when they first came up in college. And I think it's so frustrating that they come up when people are young adults and they're, trying to create stability in their life, work towards their goals. And this really, really gets in the way. So well, I really, really encourage people, whether, they feel they're experiencing some of these symptoms or they see a loved one, to get support as soon as possible, all right? I think therapy can help so much, whether or not you have this diagnosis, because a lot of people don't want to diagnose people with this at the beginning. It took a while and I had some pushback when I went in already thinking I had bipolar disorder. So 3 years later, after working with a therapist, they felt more comfortable diagnosing me, and that's fine. But you really, really can tell in hindsight when this first came up because it really changed your life upside down. How did your diagnosis go?
So I used to be diagnosed with major depressive disorder instead of bipolar disorder, but I knew it was like something more because it was like really, really intense. And it was, and I knew that I wasn't depressed because I feel like more anger or like my moods were like what actually drive me to that point. And the thing was that depressions make you worse on that diagnosis. So I struggled with that. And I will say my first episode was at 15 years old. So it took me until when I was more than 30 to be diagnosed. So more than 15 years to get the diagnosis.
Yeah, and it can take a really, really long time. If I remember correctly, They said the average like amount of time for someone to get correctly diagnosed with bipolar disorder is about 10
10
years. And that's not great, especially with how these symptoms can affect someone's quality of life. So I think it's just really important for a person to advocate for themselves. And again, like with or without the diagnosis, we can still practice self-care, and we're going to talk a bit about that later on. But this can really interfere with the person's functioning.
Research indicate that a child of one parent with bipolar disorder and one without has a 15% to 30% chance of having a bipolar. If both parents have bipolar disorder, there's a 50 to 75% chance that a child of theirs will too. If you already have one child with bipolar, there is a 15% to 25% chance that another of your children will also have it. Bipolar disorder is overall considered to be one of the most heritable of mental health disorder based on a review of family history charts.
And when it comes to this, again, genetics play a huge role. And, as we see with these percentages, it doesn't, say it's the be all end all, but Very Well Mind gave us some of these statistics. And I think it's just so important to, again, really prioritize self-care and mental health resources in the community. We know, in some places more are available than others, but something that really helped me at the beginning when I kind of like didn't want to dive into the world of mental health is just like browse online, learn a bit more about mental health overall, because I feel that can be so helpful. Sometimes we're open to learning about it, sometimes we're not. But if we know about the resources that are available, even if it's on social media, just like pictures, it's important to start somewhere because this can run in families. So now we're going to go ahead and talk about some bipolar treatments. We're going to start off with mood stabilizers. These aptly named meds help even out the mood swings, lessening the chance of high highs and low lows. Give them time to work. They take a few weeks to kick in. Then we're going to dive into antipsychotics. These faster acting drugs begin easing symptoms within a few hours so they can have your back while mood stabilizers are doing their slow and steady thing. So with mood stabilizers, a lot of these can also be anti-epileptic drugs. Again, we're not medical professionals, but because we are diagnosed with this, we have heard a lot about these. And they can use a combination of these, of course. When it comes to antidepressants, I know that's something that needs to be used with precaution because they can shift people into mania, but they can also shift people into mixed episodes. So it's just important to educate about these things because I think they can be really important to learn about so you can talk to your psychiatrist about it in an informed way. Then there's some treatments like electroconvulsive therapy, which can not only help with treatment-resistant depression, but also bipolar disorder. So it can be a good option for people with bipolar, and it's even safe during pregnancy. And of course, there's talk therapy. Working with a therapist helps you better understand your emotions while learning important strategies to help you cope with your condition. I know therapy is something that's important. I've gone to 4 different therapists throughout my life, on and off. I think it's just so important. At first, some can be more resistant, but if we go in, just again, advocating for ourselves, I think it can really make a difference. Whether it's like CBT, cognitive behavioral therapy, DBT, dialectical behavioral therapy. Something I really like is ACT, acceptance and commitment therapy, because you can really dive into just, accepting what's present in life and committing to goals. Because sometimes we want to change this. I know if the question comes up, if you had a button that you could press to have bipolar disorder to not have it, right? If you press the button, bipolar disorder would be gone. Would you press it? Of course. Of course I would press it. I'm not ashamed to have grown to accept it, but it's not enjoyable. What have been some of the treatments you've received?
I've been in therapy since I'm 15 years old, and I'm in mood stabilizers and antipsychotic.
Yeah, and when it comes to me, it's mainly therapy. I also have epilepsy. So a lot of the anti-epileptic drugs also, help with episodes. So I'm really interested in the relation between epilepsy and bipolar disorder. But overall, knowing about treatment options, I think just makes you so much more involved in your treatment. And I think there's higher rates for success because of that.
Mhm.
Okay, so now we're gonna go a bit into some of the ways you can take care of yourself when bipolar disorder is, either actively interfering with your life or you're just trying to maintain a good quality of life.
Exercise is a really good one. Trying to sleep, but it's a really hard one. One thing that Alfonso recommended, and I've been trying to use it because I forget, is the mood chart. That way you can see where or how long your mood changes are, when it happened, what are the things that actually trigger them, or if there is a reason or not. So I think that's a good way to get that idea out, or to know yourself. And then like having a schedule, or basically to know yourself. And yeah, that. And for me, exercise is really, it helps a lot. Helps a lot. But also you need to know what type of exercise, because if you do like high intensity cardio, that gives you like more energy and can actually get you to anemia episode as well. So for me, like maybe more intense workout, but less time, that work.
And when it comes to exercise, I know a lot of people can feel more energy during certain episodes. And again, they're setting all these goals so they can really go intensely into this new goal. And then they can drain themselves. So they can not only feel physically exhausted, but then mentally exhausted as well when the mood shifts. So it can be a lot. But going to the top left image here, mindfulness and meditation is something that can help so many people. Things like yoga, regular, exercise, whether it's walking or whether it's like strength training, whatever works for someone. Sleep, again, a perfect emotional support pet can also be helpful. The images of the app you see right here in the bottom left corner, this is from Daylio. This is something I've used that's spelled Daylio, Daylio, and there's a lot of other ones. But what I really like about Daylio is that they show you graphs, a lot of different types of charts. You log your mood, it has reminders. You can associate each like entry with different activities. So you can see what's associated with high highs and you can see what's associated with low lows. They're adding more updates, so you can also journal in the app, record voice messages. I've actually done this for, I want to say about 400 entries. And I really like it because it not only helps me with my psychiatrist, but in therapy. Because sometimes, when you go into a therapy session, they ask you, hey, how are you? I'm like, I don't know. Let me look at my like, let's see, how I've been for the past 2 weeks. But I just think it's so helpful if you have bipolar disorder. People can, use an app. Some people can use it by like writing down journal entries or just making their own physical copy. But I think it's so helpful. And again, routine. It's just so important. I can struggle adjusting to change because how important a routine is for me. Because, if for whatever reason I don't sleep for one night or I'm just awake for a couple hours because I slept for so long, that affects me. And trying to readjust to that can be a big struggle. Okay. So that was the presentation. Thank you very much again. I've been Alfonso.
And this is Selena.
So now it's time for some questions.
Thank you both for that presentation. And we do have a couple of things that came up in chat. Let me see here. Lindsay, you said you can relate to misdiagnosis And for you, it meant you had the wrong medication affect your life. Would you like to comment more on that, Lindsay? Are you still here?
Yeah, sorry. I'm at home today, and so I'm kind of disconnected a little bit, but I can definitely relate to the misdiagnosis piece. I was misdiagnosed from the time I was 15 until I was 27. And every time I would get on, depression medication, I would cycle faster and become suicidal. And so it was difficult for me to get a psychiatrist who actually listened to me, because I had a little bit of knowledge about, diagnoses and the differences, but I wasn't, obviously I wasn't licensed, and they just didn't want to hear it. So it was a struggle for me to be able to get the correct diagnosis and start the correct medication so I could stop self-medicating, which is what I did to cope for years. So that's my input.
Yeah, and just to add a bit to that, when it comes to self-medicating, I remember the first appointment I had with a psychiatrist. He was never my official psychiatrist. I felt so defeated. I felt so defeated because, I chose it myself. It was private. He was in Tucson. So I traveled there, and, they did my intake, and essentially they said they couldn't provide me any services because I abused alcohol during college, because I drank during college, right? And the fact that they just kind of like sent me on my way with nothing really left me, not feeling too great about psychiatric services. But there is such a big issue, I think, with self-medication and misdiagnosis. And that's why I think it's so important for us to advocate for ourselves.
I agree with that. I ended up, so the psychiatrist who finally listened to me actually was when I was in inpatient treatment. And so, my symptoms were very acute at the time because I was coming off the self-medicating. And so they didn't argue the point with me, I think, because I showed up so extreme in my symptoms, and that self-advocating was necessary for them to be able to see the difference, as opposed to, and my history with medication, I think was a highlight for them that really gave them the background, so that my advocacy and my information was enough for them to be like, oh, maybe you were right, that type of thing.
And for me, it was really hard to get the right diagnosis because I usually was in my hypomania and mania, and it was like really functional. And it looks like a superpower, even. Like I can concentrate, I can be like a super good student, a really nice, I was like the star daughter, overachiever, and all that. But it was really tiring because I had this energy and all these thoughts, and I can concentrate. And it's like when you're like in a hypomania or mania, it feels like you have like a superpower. Like you can feel more, like you can understand more, but you're also overstimulate more. So you need to be like self-regulating constantly, and it's really tiring. So I think that was the hardest part. And then when the wrong medication, that makes it even worse.
So, what we're hearing is a lot of folks are misdiagnosed, aren't being heard, and then the repercussions of having the wrong medication or self-medicating really delay getting on the right track. So what did it take to turn that around? Was it, like Lindsay was saying, that inpatient psychiatrist that finally heard her? And Talina, you said, you weren't diagnosed. You had your first episode, you thinking when you were 15, and 15 years later, you're getting treatment that is appropriate. What?
Yeah. I'm sorry. For me, it was that I was in a crisis, basically, but I didn't went inpatient because I had two daughters that no one who were able to take care of them. But the doctor was with me all the time, like guiding me and all that, and he gave me medication, and it was the right medication since the first time. So the medication was working fine, but I had to see him like every single day in order to not go impatient. So I had to be in a crisis in order to actually get the diagnosis. But it was after my second daughter. So I think it was also because they were taking it as a postpartum depression. And I think that was the key part. They were like concerned about that part instead of the whole situation. My past history about my mental health, but I feel like they were like more concerned about that. And because I was like in that point, a lot of things were changing in my life, and I always were like really honest and talk about it. And you know what? I don't feel depressed. I don't feel like unsafe now. I really did what I need to do, but this is what's going on. And the thing they were like, I was 4 days without sleeping. And he was like, you know what, if you don't take your medication, you need to go to the hospital. And I was like, I'm willing to go to treatment, but I don't have anyone else to take care of my daughters. And he worked with me, and I had to see him like every single day. For those days, I took days in my work, and I was like in contact with the doctor and all that. And after that was when I got the diagnosis and the right medication.
Thank you for sharing that. I think you bring up a point that, you know, how important it is with medication to work with your doctor. And unfortunately, I think in our system now, those appointments can be so far apart. And I think that a lot of folks I know personally who live with bipolar disorder need medication adjustment, because what works for a while, you change and you need more or less of that medicine or a different one. Do you find that to be true?
And I think you can feel it when your medication is not working as it's supposed to be, or is not like giving the effect that you need. I feel like you can tell it, you can notice it once you're like into your body, into your mind, and noticing your triggers, your symptoms, and all that, you can see.
Something I experienced was kind of like the two extremes of like an approach toward medication. With some doctors, they like didn't even want me to bring up the word medication. You know, they're like, don't talk to me about that. You don't need that. You're fine. So they like forbade me to even have an appointment with a psychiatrist for a long time. And then some doctors were kind of like handing out antidepressants like candy. I hate to say it, but they were really just handing it out. And I had boundaries at those moments. So I'm like, no, I don't think I need that right now. I'm trying to like manage things on my own. But had I taken it at that point, who knows how that would have affected me? Who knows if it would have ended up in a mixed episode? I mean, a hypomanic episode can sometimes feel like a vacation for me, and I can see it as a good thing, but you never know if it'll end up in that mixed episode. I'm overall like more conservative about medication, so I want to see, you know, like what I can take and if I can take it when I need to take it. But something I think that could be so helpful is if more psychiatrists still offered therapy. Since psychiatrists are just so focused nowadays on medication management, I think there's a lot lost when it comes to communication between a therapist and a psychiatrist. Some places are really good about, you know, keeping them informed, but I think it's different. It's different when, you know, you talk to a psychiatrist for a really long time, when you just see them for a quick appointment and they're just like, okay, new meds, let's see how they work by. And it's just like, okay, we'll see how they affect me. But I think there is a lot of work that can be done, but I think with advocacy, boundaries, and, you know, just building public awareness, I think it can really, really help.
So Alfonso, you're saying there can be a lack of continuity of care due to lack of communication between treatment team members, specifically a therapist and a psychiatrist.
Right.
so you're the bridge between them and you're, and you have to advocate for yourself.
Mhm.
Mhm.
So in the chat, we've got a question. What's a usual diagnosis before the psychiatrist would diagnose bipolar? And Talina, I think you said depression was
Yeah.
what started with you.
Well, talking to other peers or like in my work, in my experience, for me was like chronic depressive disorder. And I mean, I had some days that I feel depressed, but for me it was like more mania and hypermania. So I was like more like, I don't feel depressed. I don't feel, but they were like, oh, it's because you're like overcompensating your symptoms. I'm like, I don't really feel depressed. And you get confused. And you get to that point that like, I don't even know what I'm feeling now because I'm telling you that I'm feeling this, but you're saying that I'm overcompensating or things like that, and you get confused. So yeah, I feel like the more usual diagnosis that you had is like depression or anxiety, or both.
Mhm.
For me, something that I saw with the primary care provider I first saw when I was feeling actively suicidal, they gave me depression. Then when I saw my first health home, um, it was an adventure with them. They just kind of like didn't listen to me at all. I ended up seeing my chart and they gave me adjustment disorder, which really frustrated me, just because I really went in prepared, and I was very confident with my symptoms. And while, I didn't necessarily want a diagnosis of bipolar, I wanted something accurate and I wanted the truth. And I felt really invalidated with what they gave me. But eventually, I worked with a therapist for 9 months. They were really, hands-on. They really wanted to collaborate. And they eventually, after the 9-month mark, they felt comfortable giving me the bipolar 2 diagnosis. But I think depression is seen a lot. And when when they misdiagnose it as depression, that's when they can prescribe antidepressants, and that's when they can get into, muddy territory.
So we have a question about genetic testing being done. Is genetic testing being done?
I don't know that much about genetic testing. I just know it's one of the diagnoses that are very, very, heritable. I know that there's probably information online about that. I know some people who, they have it as like their spouse has it or they have it and their kids have it as well. I know people are very, very conservative about diagnosing children with bipolar disorder, but I don't know too much about that.
I don't know either. I didn't get one done, but being super honest, once that you learn about the diagnosis and you see, for example, in my personal experience, once that you learn about your diagnosis, and I start like putting attention to my mother's behavior, my family's behavior, and you see like, okay, I see. And that was for me normal. And that was for me like something that, oh, that's how they are, but it's not normal. So you can tell.
When it comes to heredity, they say that it always comes from an immediate family member, less from a cousin or something like that. I definitely saw depressive episodes happening with my father. I don't think I've ever noticed any like manic or hypomanic episodes, but I know that with, generations that came before us, mental health wasn't talked about as
And they're
openly.
not official.
So, if it's hard to diagnose nowadays, you can only imagine like 20 years ago.
Kathy, you have any information you'd like to share about genetics and bipolar?
Well, I think there is a strong family history. I also have read information where teenagers, males that are diagnosed with ADHD, 60% go on to be diagnosed with bipolar. But the question that I would like to raise in conjunction with that is, I think there's in psychiatry, there's been a long period where people were misdiagnosed with personality disorders, mainly borderline personality disorder, which, it takes a clinician quite a while to tease that out and really look at, there's certain things that can differentiate between the two. But I think this is one area that our population has been very hurt and very traumatized by, because the treatment is very different. And so I really appreciate, what you guys are sharing. And I think the strong piece, the main thing here is, learning to advocate for ourselves and insist. And of course, that's a sign of something wrong with us too, but it's something we have to do.
Yeah, and I'm glad you brought up borderline personality disorder, Kathy, because there is a lot of confusion between the two. But when it comes to bipolar disorder, that's why we really brought up the timeframes for hypomania, for mania, for depression, and anything else, because that's what really differentiates that when it comes to the DSM.
Well, and you can have both too, which really complicates the picture.
Yes.
So I'll add one more thing. During my years of mental illness, I had ECT and insulin shock. And you were kind of saying that this is a viable treatment, and I think we need to be very careful. And I agree, it can be a good form of therapy in certain circumstances, but it also, unless they do the dominant side or whatever, they're very careful, you can have brain damage like I got. And so this is something that you really have to think about before you jump into it.
Mhm. So both of you, Talina and Alfonso, live with bipolar and you work full time. And you did share a bit about your experience with treatment, medication, and self-care. But I think that, well, I don't know if I have a question here. How do you balance it? How do you manage it?
For me, I think medication has been key. Medication has been really important for me to be in a baseline or more stable. Another thing is like to know yourself, to know when you can function, how you can function, and all that. For example, for me, in order to complete or be concentrating, I need to be talking and do other things at the same time. Know how you work, how your brain works, how you get things done. So I feel like you try different way to do things in order to know how to get it done. So that's how I do it. I do have a schedule, and I'm a single mother too, so I try to get like a really organized schedule in a way that, okay, so every night get my girls to bed at the same time, get my space, my time to do my things, try to not get my work to home and things like that. Try to just like follow the rules to my rules, set boundaries to myself, respect that. Otherwise I get like overwhelmed, like saturated, and it's hard. And exercise.
Mm-hmm.
When it comes for my self-care, I think therapy is really important, but I also think it's really important, whatever I do between sessions. I've had it on and off for 8 years now, and while it has been a help, I think it's also been really important for me to focus on the 8 dimensions of wellness and a routine. I know being social and having those supports is so important. Family, friends, again, having that routine, having that discipline. I feel so much better after I exercise. but it's so difficult. It's so difficult to keep on pushing myself to continue. Because again, I can feel all that motivation and have, the couple days when I keep on doing it. And I'm like, I don't want to focus on if I'm hypomanic or not. And then I end up crashing, and that really doesn't help. But some things that I think can be a bit simpler to do are something like daily meditation, journaling daily, a gratitude list. When I'm working on that spiritual dimension of wellness, I think that really helps me out. When it comes to my job, I think a work-life balance and trying to see how I can, just always keep at the front of my mind that if I'm not taking care of myself, how am I going to help others? Because I think that's such an important part. I also think, sleep. I'm definitely a night owl, but I try to get at least, 3 sleep cycles. They're roughly about an hour and a half. So 4.5 hours of sleep or more. Definitely could do more. Ideally 8 hours, but I know myself 3 hours is not going to work. But 4.5 hours or more is definitely best. Of course, 7 to 9 hours is ideal. But when it comes to intellectual dimension of wellness, taking care of myself, learning about it, about what helps me, what isn't really the biggest help, and what I can prioritize. Environmental, again, spending time outdoors in nature, it's so important, because just that fresh air, taking a break from screens can really help me. Emotional, again, my mood log, but also making sure I express things, not only in therapy, through journaling with friends, and trying to be as strict as I can with myself when it comes to the financial dimension of wellness. Because we know with mania and hypomania, it can be a party sometimes.
Yes. And another thing that I think is really helpful is to have people around you that know you, and then they can tell you, hey, you're being rude, or you're being, I don't know, hard, or you're being because sometimes you don't notice it. You are like answering in a really harsh way or in a really bad way that you didn't notice. So I think that helps a lot. Um, and yeah, to have a safe place to express, or someone to actually to be yourself and be okay being yourself.
Mhm. And one of the things in self-care that neither of you have mentioned, but it has to do with diet and nutrition.
Right.
Yes.
I definitely do better when I'm focusing on that. I struggle too, but definitely healthier drinks, reducing caffeine intake. I know what types of caffeine my body can handle because of my epilepsy, but trying to make sure the caffeine isn't negatively affecting my sleep. When it comes to diet, I know that there can be, certain diets that help, and that's where the discipline comes in. But if I'm doing better with, like, let's say the physical dimension overall, I'm focusing on the diet, but that one's a bit difficult to focus on as well for me.
And the thing is, it depends on the day, because you can be super organized and strict when you're like baseline, and then when you're like in mania, you're like, oh, whatever, overeating, and just like partying in your brain.
So,
And
go
I
ahead.
wanna add a little bit more on the social dimension of wellness, because I think the thing that has taken the biggest hit for me has been my relationships, unfortunately. Sometimes people are in your life for, a long time, and sometimes they kind of just tap out and they say, I just can't handle this anymore. And it's frustrating, but I think knowing myself, knowing that I'm my biggest support, having family around me, and just really appreciating the people who stay for the long runs, because I know I can be, not the best at sometimes, but I think my intentions are clear. So really educating the people in my life has helped them stay a bit longer. Letting go of expectations and just making sure to be mindful and enjoy, the times that you can spend with people, because, relationships can be hit a lot with friendships or romantic relationships, any of that.
Okay. And that kind of touches a little bit on stigma without having said it. What's your experience or comment there?
When it comes to stigma, I think people just don't have a good idea of what it actually is. So I try to educate people who are open to learning about it, but I think it also has a lot to do with how a person just kind of like presents it, right? If they see it as a burden, if they see it as something that, you know, makes them maybe not worthy of having people in their life, that's where I think it can really affect, you know, their relationships. But working on my self-worth, working on my personal development, I just kind of show up, and this is something that's a part of me. It does not define me. If people want to see it as that, okay, that's a filter. I won't have you in my life, or I can set a strict boundary. But I think just advocating for myself and seeing that I'm a person first, you know, this is just another part of me, in the same way that my epilepsy, right? You know, some people, they have diabetes, right? And that's just a part of their life. And I think there's a lot more leeway with diagnoses that have to do with physical health versus mental health. But, you know, just continuing to advocate for ourselves, and letting people enjoy the highs and lows with me, right? Like, I'll take you on this journey if you're down, because, you know, I can help you when you're feeling down. I definitely think I'm more empathic because of this. And when people bring stigma towards me, I'm open to talk about it. I've definitely gotten good with not taking things personally, unless I'm in that mixed episode. But, you know, it always says more about them than it does about us. So continuing to do what I do best, focusing on my strengths, and knowing that stigma is probably always going to be there, and we can't wait for it to go away until we live our best life. But we can try our best to, you know, inform others. What would you say about stigma and how it's affected your life, Fatima?
I feel like there's still need a lot of education about a lot of diagnosis, empathy still needed, and but yeah, nothing to add on top of what you said. All you
Okay.
said.
So we have it in the chat, one of the attendees here today says, I'm diagnosed with bipolar 1 and borderline personality disorder, and it took many years of treatment to figure that out. I think the system is getting better at diagnosing due to so much awareness in this field. With your years of being in treatment, have you seen improvement? And with the people that you work with, the peers coming in for services at Hope that are living with various diagnoses and illnesses, are you seeing improvement?
I think it's hard to see improvement here in Nogales because it's such a small town, and there we used to have just one help home hasta el año pasado, sí, until last year. We have one more help home, so there's just two providers that do actually psych services and medication management here. So I feel that it's really hard to see the improvement, and I see improvement in the people that actually advocate themselves, and the people that is constantly expressing, you know what, this is not working, I need to try something else and look for different options.
I think something that can be very helpful is empowering the person and educating the person. Because when a person not only advocates for themselves, but feels good enough to practice self-care, that makes a huge difference. And personally, when I've worked with people individually, I can really help educate them about bipolar disorder, and it just helps them build self-awareness. Whether they're open to medication or not, you know, that's a personal choice. But I think it's just so important to educate them, because without that, they can just kind of be overwhelmed because symptoms come and symptoms go. There's highs, there's lows, both at the same time. It's so overwhelming. But when they hear that someone else not only, you know, provides services, but lives with it, I think it really does change the tone of the conversations. Because so many times, if they talk to a doctor or a therapist, they're like, okay, like this person knows their stuff, but they don't necessarily relate to my experience, right? Which is fine, but I think it's so important to always remind members or, you know, people seeking services that while a person might be an expert in their field, you are an expert in your own lived experience. And when you work together with them, I think that makes all the difference, right? Because sometimes we think they're totally in the power position, but you know yourself, right? And the more you work on that, I think the better quality services you can receive. And I've seen the more I bring up, the better questions I ask, the more I advocate, the better services I've received.
Lori, I have wanted to comment on an area where I think stigma is still very prominent, and that is in the military. I grew up in the military, and my mother was misdiagnosed most of my life, and they had her on medication. None of it ever worked. And then I had the same thing. I married the military. So with my children, of the 6, 3 of them were diagnosed with bipolar, one with bipolar as well as borderline personality disorder. And again, it was always, oh, is your husband gone? Oh, that must, it's you, the mother, it's the kids, it's the this, there's absolutely, I think that environment is just a really tough nut to crack. I think they're starting to, but I don't know, I guess it would depend on where you are in the world, because you're at the mercy of whatever doctors are available for the military to see. So.
Right.
Excellent point, Sherry.
And I think we need to remember the words she used. We are at the mercy of these doctors.
Right.
And speaking of being at the mercy of the doctors, also in chat, we have a question. Did you go through step therapy to find the right meds? Now, step therapy has to do with an alternative to medication first, or a less expensive medication than one that may work better. So what would you say about the process to get it to the right meds?
For me, no, well, at the beginning, when I was taking antidepressants, I stopped taking them because I knew it was like not helping me, and I went years without medication. And until I was diagnosed, and I got that crisis, I got the right medication. I don't know how, and I don't know, because it's really rare that you get the right medication at the first time, or the right doses at the first time. And it actually worked for me, and it was at the beginning, so not for me.
I've actually never heard of this step therapy before. None of the doctors who work with me spoke about it. But when I went to any psychiatrist, I actually never ended up taking medication with a psychiatrist. Most of my medication came in like conjunction with treatment for epilepsy. So my neurologist prescribed things that not only helped with seizures, but helped with stabilizing mood. So a huge part of self-care for me is making sure I don't have seizures, because then that really affects everything afterwards. But most of that treatment comes with the neurologist.
Right. Yeah, the step therapy, the system wants to provide quality care, I believe. But they also want to save money.
Yeah, and it was really hard to get the medications to be approved. I remember that. It took me like one day to actually get the medications, and the doctor was calling the insurance, and they were like actually like actively calling them and asking to approve the medication during the whole day, because it was like an emergency. I had to be inpatient. I was in a crisis. It took me a whole day in order to get the medications.
And when it comes to like insurance and treatment providers, I started with the PCP. I went, to a neurologist, and that's back when I had access. now, because I have Blue Cross Blue Shield, I have a bit more choice. And eventually, you know, that doctor stopped accepting access, but I could still work with him because of my insurance change. So I'm lucky there. And then eventually, you know, a little over a year ago, I got close to almost dying because of a seizure. I was in the ER. It was not great. So because of that, finally I was sent up to Mayo Clinic to deal with my seizures. And because of that, they finally approved an extended release version of a medication that other doctors didn't even try to get. And that has helped me so much. Not only take less like pills and tablets, but really help me, you know, just feel more stable overall. So unfortunately, a lot of those, you know, really intense things have to happen to you before you can get that. But I encourage people to work on personal development, to be as assertive as possible, and to set boundaries, because, you know, it's not about being a difficult patient. It's about really insisting, really insisting.
Thank you. Are there any other questions that anyone has for Talina or Alfonso? Or any comments about what you've heard today?
I did see a comment about the PowerPoint, if it'll be available. I can definitely send that to you, Lori, and I don't know if you can make it available to anyone who wants it.
Okay, thank you. Susan did send me the PowerPoint.
Okay, perfect.
Have it, but if Hope's okay with it going out, this whole meeting, your presentation is being recorded. So that will be posted on the NAMI YouTube channel, so people can access the presentation there. Because I think what you bring to it is more than what we see. The PowerPoint is excellent, but what you bring to it brings a richness.
And something I think that's just so important is to have conversations with people. So many times we just see the diagnostic criteria and it can be so dry. And, you know, people look at it, it's like, I don't know what these things mean. Like, I don't know what psychomotor agitation is, you know, I don't know like what all of these mania diagnostic symptoms are, right? Because what a person's normal is to when a person's heightened sense can be very different, you know, on a case-to-case basis. So having conversations with people, I think, really makes all the difference. And using human speak, just talking, really makes the difference. And humor is something that has helped me survive, you know, with the highs and the lows. Humor has helped me take myself out of any type of victim mindset and be like, you know what? I'm gonna see how I can make it work, because I mean, this is here. So let's go.
Excellent. So Kathy, you're up.
So it's my job to thank the speakers and all of you guys for participating, but especially the speakers. And I think what you've done is very poignant in the sense that you're offering hope. You're showing that treatment works. It's not linear, and we all struggle. And just by role modeling for a lot of, especially younger people that are just starting this journey, the suicide rate is so high with people with bipolar. And you know, I have my kind of goosebumps because treatment does work. And you know, we all have to empower ourselves, and you guys have really role modeled that, and it's hard. So thank you for sharing, and I hope a lot of other people have access to this video and what you have to share.
Thank you,
Thank
Kathy.
you.